morning, everyone, and welcome to today's webinar organized by the Malaysian Perioperative Medicine Society. My name is Hema Yamini, and I'll be your moderator for this session. Before we begin, we'd like to warmly invite all of you to join us as members. You can follow us on social media platforms for updates on upcoming events, webinars, educational activities, and resources that support continuous learning in perioperative medicine. Before we begin, just a few quick housekeeping reminders. Please use your full name when joining so we can identify you easily. Kindly keep your microphones muted throughout the session to avoid background noise. If you'd like to speak, just message us in the chat and we'll enable your audio. You may be asked to keep your video off to reduce any distractions, but do use the chat box. The host will share important links and information there. We'll have a dedicated Q&A session at the end of the presentations. If you're on the Zoom platform, please type your questions in the chat. But if you're watching on YouTube, you can post your questions in the YouTube chat. If you get disconnected, please rejoin us through our YouTube channel at My Periop Med. And finally, please remember to fill in the CPD registration and feedback form. The link is provided here, and we'll also provide a QR code at the end of the session. So I'd also like to share an exciting announcement. The first Malaysian Perioperative Medicine Symposium will be happening on the 28th and 29th of March at Connexion Conference Center in Kuala Lumpur. So we warmly invite all of you to join us. I'll just share a video of the symposium.
We are excited to announce the first Malaysian Perioperative Medicine Symposium 2026. Jointly co-organized by Malaysian Perioperative Medicine Society, Malaysian Society of HPB Surgeons, and Malaysian Society of Regional Anesthesia. The shared goal is to improve perioperative outcomes and reduce morbidity through coordinated evidence-based care. It features 3 parallel tracks and covers a comprehensive range of topics, including prehabilitation, nutrition, and preoperative optimization, enhanced recovery pathway development, acute and regional pain management strategies, perioperative blood management, and multidisciplinary models for improved surgical outcomes. We invite you to participate in this historic first symposium and to share the event with your colleagues, trainees, and professional networks.
So, all right, with that, let's just get started. Before we hear from Professor Francis Chung, I'd like to set the stage with a short overview of obstructive sleep apnea in Malaysia, why it matters, and why her topic today is so timely for us. So, OSA obstructive sleep apnea is one of the most common sleep disorders worldwide. It affects about 1 billion people, but despite how common it is, it remains significantly underdiagnosed. In Malaysia, we estimate a prevalence of around 15 to 20% based on Asian population data. However, most patients never actually get diagnosed, mainly because of low public awareness and limited access to sleep services. This problem becomes even more pronounced in resource-limited settings, such as district hospital, rural areas where diagnostic facilities are scarce. So OSA is not only common, but it's also frequently missed, and that has major implications for our patients' outcomes. So OSA is far more than just snoring. It affects multiple body systems and it carries significant health risks. From a cardiovascular perspective, OSA is linked to hypertension, arrhythmias such as atrial fibrillation, heart failure, coronary artery disease, stroke, and even pulmonary hypertension. Metabolically, it contributes to diabetes, weight gain, as well as insulin resistance. It also affects the brain. Patients often struggle with poor concentration, memory issues, and mood disturbances. And importantly, daytime sleepiness leads to higher rates of motor vehicle and workplace accidents. When moderate to severe OSA is left untreated, the overall risk of death increases and hospital outcomes are poorer. So it's important for us to recognize and manage OSA early. So now let's look at key challenges in managing OSA in Malaysia. So Malaysia has no published national data on the number of PSG machines or sleep labs. Access to polysomnography, PSG, remains limited to selected tertiary centers and a small number of private hospitals. For example, in a place that I practice, which is Kota Kinabalu, Sabah, Sabah has only 4 sleep labs. We have a population of 3.5 million people, but we have 4 sleep labs, 3 under Ministry of Health and 1 in a private hospital. This limited capacity translates into long waiting times for patients, geographical inequity. You can see how 3 of the sleep labs are located in this area and 1 is upcoming in Tawau. So this also leads to underdiagnosis, especially in rural areas. Other key challenges beyond limited sleep labs, we have a shortage of specialists and trained sleep technicians. This limits how many studies we can run and how well we can support our patients after diagnosis. Our sleep clinics, which is run once a week, are always full of patients. We have up to 60 patients in each session. Second, CPAP cost itself. Not only CPAP, but all those devices, the masks and all that, the cost of it remains a major barrier. Many patients have to pay out of pocket and social welfare approvals can take months and this delays treatment. Third, awareness is still low. Healthcare providers tend to underestimate the seriousness of OSA, so screening rates are also low. And finally, because of all these factors, many patients come to us late, often after they've developed hypertension or ischemic heart disease, diabetes. When it's already developed, that's when they come to us. And these challenges highlight why early detection and accessible pathways are so important. Current progress and opportunities in Malaysia, one of the biggest shifts is the growing availability of level 3 sleep study, the home sleep testing. It's a more accessible and lower cost alternative to PSG, and we are seeing that it's being used more widely in both public and private centers. For a large state like Sabah, where geography is a major barrier, this level 3 sleep study really helps us. And we are also seeing a stronger collaboration across specialties. Respiratory, ENT, neurology, psychiatry, dental sleep medicine, and primary care are increasingly involved in OSA care. Another positive development is the rising number of clinicians trained in sleep medicine. In the last 2 to 3 years, we see more and more physicians are taking the exams and being trained in sleep medicine. So this is good. This helps increase our diagnostic confidence and capacity. And we have also started using the screening tools that are simple, low cost, and very scalable. Stop Bang, Berlin, and Epworth sleepiness scales. They are now being widely used in primary care. So these tools allow us to identify high-risk patients early, even in centers without PSG. So this is one of the efforts that we have made in Queen Elizabeth Hospital, Sabah, where we run a sleep MDT since 2023. We do it once a month, and this is for complex OSA patients. So we bring together respiratory, ENT, maxillofacial surgery, bariatric team, as well as speech therapists, allowing us to assess patients in a very coordinated multidisciplinary way. During each session, we review imaging, perform bedside nasoendoscopy when needed, and discuss cases as a team, and we communicate this unified plan to the patient. So the patient doesn't have to go to various clinics, and we can all review the patient together. So with all these challenges and the opportunities we've started to build, the key question now is, how do we move forward? What practical steps can we take, even in a resource-limited setting, for us to improve early detection, make sure that the care is streamlined, and make sleep services more accessible to our patients? So this makes today's topic very relevant as we work to strengthen the sleep services in Malaysia. So it's my pleasure now to introduce our speaker, Professor Dr. Francis Chung, who will be speaking on OSA risks and complications, how to do better in a resource-limited environment. Professor Dr. Francis Chung is someone whose work has directly shaped how we practice sleep medicine here in Malaysia. She trained in Hong Kong and at the University of Toronto, where she is now a professor and the ResMed Chair in Anesthesia, Sleep and Perioperative Medicine Research. She has served in major international societies. Her research has transformed clinical practice worldwide. Most of us routinely use the Stop Bank tool, which is a screening tool that she developed that has become one of the most widely adopted methods for identifying undiagnosed OSA. With over 500 publications, numerous awards, and more than 480 invited lectures, Professor Chung continues to influence sleep medicine globally. It is truly an honor to have her with us today. Please join me in welcoming Professor Dr. Francis Chung.
Hi, thank you, Dr. Yamini. Okay, did we switch now over to the slides? My PowerPoint?
Yes,
Dr.
Prof.
Yes.
Okay, great. Everybody can see the PowerPoint. So thank you for your kind introduction. Oh, so actually there is a problem. Now I cannot advance my PowerPoint. Oh yeah. So my research are supported by various foundations and funds, and I have a conflict of interest. The Stop Bank is proprietary to University Health Network. So the objective of this talk is to actually understand the post-op complication of surgical patient sleep apnea, how best to screen for sleep apnea, and the optimal management of surgical patients. So this is a 50-year-old female who is obese, who has sleep apnea history, and she is CPAP non-compliant. She comes for shoulder rotator cuff repair in Chicago, USA, and she had a general anesthesia plus interscalene block afterwards. And then after she was discharged home, but the son discovered that she had a respiratory arrest the next morning at 10:30. So at the present, sleep apnea is worldwide. It is actually nearly 1 billion have mild to severe sleep apnea in the world, and over 400 million adults have moderate to severe sleep apnea globally. I am Mr. Bakley's attorney. Do you promise to hit the vein, the whole vein, and nothing but the vein? So help you God. Now, the Society of Anesthesia and Sleep Medicine, together with the ASA, did a deaf and near-deaf registry for sleep apnea, and we collected cases, and we find that these patients were mostly ASA 3. Their mean age was not too old, it was 53, and BMI 38. Most of them are inpatient, and most of them are elective surgery and general anesthesia. And the outcome, death or severe brain damage, is 63%. Critical event is about 37%. So where does it happen? In the step-down ICU, it's about 14%. In the recovery room, 20%. In the ward, which is the majority, 56%. At home, around 20%. And when does it happen? The end of anesthesia to event. In the PACU is about 2 hours on arrival. Step-down ICU, 12 hours. The ward, 16 hours. And at home, about 28 hours after. So, and the patient outcome, and you can see here, the death or severe brain damage is by blue, and more of people have death or severe brain damage when this happened in the ward or at home. But if it happened in the PACU ICU, most of them will have critical events. And the patients are monitored at the time of the event, then there's less death and less brain damage. So essentially, when you have post-op PEP use, supplemental oxygen, and also monitoring, they are not completely protective against catastrophic events. So we actually asked the question whether any unrecognized sleep apnea patient or undiagnosed sleep apnea patient, are they associated with post-op cardiovascular event in those who are undergoing major non-cardiac surgery? And this actually involved about 9 centers in 5 continents, and Malaysia is one of the major contributing two hospitals in Malaysia, in KL, and Professor Wang. So essentially, when we collected over 1,200 patients, the no sleep apnea is 1/3, mild sleep apnea 1/3, moderate sleep apnea about 20%, and severe sleep apnea about 11%. And these patients just come and we did home study on them. Is actually just a sleep apnea study, is a home sleep apnea test. And the cardiovascular event occur in nearly 20% of the patient within 30 days after surgery. So the cardiovascular event are death, myocardial injury, congestive heart failure, atrial fibrillation, embolism, and strokes. So somehow I cannot advance my slide. It's stuck. Okay. Okay. So essentially, the OSA associated with the event, it is actually no sleep apnea is about 14%, mild sleep apnea 19%, moderate sleep apnea about 22%. But you see that those who have severe sleep apnea, 1/3 of them have post-op cardiovascular event. So this is a Kaplan-Meier estimate of the primary composite outcome. And essentially, the non-sleep apnea are in black, and this is the reference point. Those with severe sleep apnea, their just hazard ratio is 2-fold higher, is statistically significant. But the moderate sleep apnea and the mild sleep apnea are not statistically significant. So what are the pre-op predictors of post-op cardiovascular event, and what are the population attributes? And essentially, age account for 56%, renal impairment 9%, peripheral vascular disease about 8%, but sleep apnea contribute to 22% of the post-op cardiovascular event. And when we analyze between the severity of sleep apnea and MI, those who have severe sleep apnea, 10% would develop MI within 30 days. And the adjusted hazard ratio is 3-fold higher. So how about stop bang? With the stop bang, you can see here, the stop bang 0 to 2, the reference point, but when it's 5 to 8, is 70% higher risk, and stop bang 3 or 4 is 50% higher risk. Now, during the first 3, let me move this away. So during the first 3 post-op night, actually, patient with cardiovascular event, and the only difference that we have is the longer CT80. What is meant by CT80? CT80 is that the duration of the patient having oxygen desaturations more than 80%. And we find those who have cardiovascular event, they have 23 minutes. And those who don't have cardiovascular event are about 10 minutes. So, okay, here. So the global surgery is 330 million per year. And therefore, we are talking about 1 in 10 have unrecognized severe sleep apnea. And these patients all have higher risk of cardiovascular event. So we also look at the post-op outcome in looking for the literature. And we find throughout the literature doing a meta-analysis, post-op complication is increased by twofold. Cardiovascular complication increased by 50%. Respiratory complication twofold. Hospital and ICU readmission is 2.6-fold. So we can say that it's not just sleep apnea. These patients have morbid obesity and they have comorbidity. And all of these will contribute to anesthesia risk. And you will say there's a clinical conundrum here. Many patients with untreated sleep apnea, they are undergoing surgery every day. Why do not more patients have death or adverse event? So we have to recognize the sleep apnea in surgical patients. There are known sleep apnea, there are unknown sleep apnea, and there are patients who are treated with CPAP or other treatment or untreated. So essentially, when the patients after surgery, they actually don't sleep so well, the sleep efficiency decreases, and then they often have light sleep during the post-op night, and the deep sleep are increased. And also, the red one is the REM sleep, the rapid eye movement sleep, which will happen on post-op night 3. So this looks at the AHI of the patients who have no sleep apnea or mild sleep apnea. And you can see during the different night, they are very similar. And with the moderate sleep apnea and severe sleep apnea, the AHI are increased, and also they are very similar. And you can see patients at risk of sleep apnea. There are many different kinds, not just morbidly obese patients. You are all familiar with the Stop Bang questionnaire. However, the questionnaire is sensitive, but is not so specific. That means there are some false positive. But the Stop Bang 0 to 2, we have we can rule out any patient who will not have sleep apnea. And Stop Bang 3 or higher, then indicate the patient very likely may have sleep apnea. And when we talk about high Stop Bang, lots of places, they don't use the Stop Bang 3 cutoff. They use Stop Bang 5 or higher. And essentially, when it's very high specificity, it's a positive test than ruin. So means that if you have very high Stop Bang score, you are most likely to have severe sleep apnea. And when a Stop Bang 5, 35% have severe sleep apnea, Stop Bang 6, 42%, and 7 or 8, over 60%. So the risk of having higher risk is associated with higher score. We also look at geographical regions, and it's very interesting. The AUC is very high everywhere except East Asia. Even South and Southeast Asia are high. But in East Asia, with the Chinese and the Japanese, they don't have very high BMI, and the AUC is actually low in the patient. And we look at different ethnic groups, and this applies to Malaysia in that sense that here, when you look at severe sleep apnea, the bottom graph, the Chinese and the Indian, actually you can see the lines. They actually have much lower risk of having sleep apnea. But if you look at the Malay, and you can see 17% risk of having very high sleep apnea when the Stop Bang score is 4. So even here with the moderate sleep apnea, you can see the Malay is very different compared with the other Southeast Asian group and Caucasian. So I will go quickly. Due to time, we will skip this. Society of Anesthesia and Sleep Medicine guideline, we did a guideline on what should we do. Because a lot of the patient, when they come, they may not be on CPAP. Not that they should not be on CPAP, they just don't want to use CPAP, or they are not adherent to the CPAP. So we actually say these patients may proceed to surgery provided strategy for mitigation of post-op complications are implemented. And we should explain the risk to the surgeon and the patient. And when should we refer these patients to sleep specialists? These anesthesiologists and the sleep physicians often do not agree on it. The sleep physicians want referral if the patients do have sleep apnea and they're non-compliant. But the anesthesiologists, due to the time restraint and resource restraint and the pressure of having surgery, they want more evidence. And the patients that I got 99 problem and snoring is only one of them. So when should we actually delay surgery or cancel surgery and additional consultation? The group, the Society of Anesthesia and Sleep Medicine, only have 3 conditions that we should delay surgery or cancel surgery. The first one is hypoventilation, which is the hypoventilation syndrome. The second is severe pulmonary hypertension. The third is resting hypoxemia of uncertain cause. So only these 3 conditions you should consider actually canceling. The sleep apnea patients are very common. And we publish a guideline on intraop guideline. And often enough, the patients are difficult to intubate and also difficult to ventilate. And also a lot of times in the literature, there are reports of patients having death or near death. And we actually find that it can be related to the opioid doses. And when the opioid doses is more than 25 milligrams, the odds ratio may be 3-fold higher. Actually, there is a retrospective looking at database in surgery in USA, and they do find the complications are lower in regional anesthesia versus general anesthesia in OSA patients. And for sugammadex, also there may be some advantages as well. How about day surgery? In the day surgery, essentially, we think the patient can go forward if they have optimized medical condition, very little opioid are needed for post-op, and they are either treated with CPAP if they are sleep apnea. If they are suspected OSA, and if they are optimized comorbid condition, minimal opioid, you can still go ahead. However, if they are not optimized, then we should cancel day surgery. This is a true case of a patient having UPPP and who actually arrested and died later on. So there is some recommendations. Some of the ENT patients should not be done as outpatient. And one of the main things is higher pre-op AHI or tongue-based surgery. If the patient is going home after surgery and they have sleep apnea, advise them to sleep in a recliner so that they are not lying down and have an obstructed airway. And also communicate with the surgeon, the nurses, and the patient of the risk, and avoid opioid if possible, and use NSAIDs and other medications. Also, if the patient really needs narcotic, then ask them to take half and see how it works, and then add the other half. Essentially, if the patient have recurrent PACU event, if they have apnea, if they have slow respiratory rate, if they have oxygen saturation, or if they have pain sedation mismatch, and there is increase of respiratory complication if the patient have PACU event. So in those who have PACU event of either slow respiratory rate or oxygen desaturations or apnea, if they are low risk of OSA and they have event, the respiratory complication in the ward is about 11%. However, if they are high-risk sleep apnea and they have these events in the PACU, then 1/3 of them may have respiratory complication in the ward. Now, patients are often known complying with CPAP. And essentially, what can we do? So we asked the question, can we just give oxygen therapy to these at-risk patients with OSA? Do we really need CPAP? And you are asked about Malaysia. It is resource limited. Should we just give oxygen? We did a study on post-op oxygen therapy in patients. We randomized the patient to receive oxygen, which is 3 liters per minute with nasal prong for 3 post-op nights. And we compare with those who have no sleep apnea. And these are patients who are newly diagnosed with OSA and with the AHI more than 5. And the green one is those who are on oxygen. The red one is not on oxygen. And to no surprise, those who are on oxygen, the oxygen desaturation index is actually much lower. And the overnight oxygen desaturation, less than 90%, are lower. But there is a caveat. We did monitor the patient with oximetry and transcutaneous CO2. And we find 11% of the patient have very high transcutaneous CO2, indicating that the respiratory depression is more than 55 milliliter mercury. When the PaCO2 is 55, the patient is acidotic. So this is a theoretical pattern of carbon dioxide narcosis. So essentially, the ventilation, if it slows down, if the patient is on room air, when the oxygen saturation decreased to 60 millimeter mercury, which is 90% oxygen saturation, the alveolar PaCO2, which is the green line, would rise to 65 millimeter mercury. However, if you give these patients oxygen therapy, when the alveoli is actually SpO2 is at 80 millimeter mercury because you're giving these patients oxygen, the PaCO2 is 80. When the PaCO2 is 80, the patient becomes very drowsy and obtunded, and there may be upper airway obstruction. And this is what is the term called carbon dioxide narcosis, and the adverse event can occur in these patients. Now we also ask another question. What is the effect of high-flow nasal cannula, which is now very common, and it is easier to use than trying to get these patients on CPAP. So we also did a study, systematic review and meta-analysis on the literature. And we actually find when we give high-flow nasal cannula oxygen, it would reduce the AHI by 36%. But it does not increase the SpO2 much, only by 0.3% compared to baseline. So essentially, when we did this study, the systematic review and meta-analysis, we find that supplemental oxygen therapy significantly reduced AHI by 31%. It does increase the SpO2 by 5%. But what happened when we give CPAP? In the CPAP would reduce AHI much more by 84%. It will increase the SpO2 by 3% compared to the baseline. So essentially, CPAP was 53% more effective in reducing AHI than supplemental oxygen therapy. But both treatments have similar efficacy in increasing SpO2. So who are these patients who require oxygen? So if they have unrecognized sleep apnea, they are mostly male, they have large neck circumference, they have higher ASA physical status, higher stop bang score, and they mostly undergo intraperitoneal or vascular surgery. So this is another patient who is 62 years old, hypertension, with coronary artery disease and obesity for total knee. And the patient has stop bang, and the serum bicarbonate is high. So this patient may have obesity hypoventilation syndrome. So essentially, we should not go ahead and actually, this patient needs to be treated. So what happened in the literature? Do we have evidence for CPAP, how effective it is? And actually, we did a study on the APAP. APAP is auto-titrated continuous positive airway pressure. And it's a very smart device. It will sense the obstructions in the airway and titrate the APAP for the patient. So we randomized the patients to APAP or no APAP, and these are newly diagnosed OSA with moderate to severe OSA, and they receive APAP 3 nights pre-op and 5 nights post-op. And we did the study. Again, patients who received the CPAP in green, they would have less AHI, they would have less obstruction, less hypopnea, and less respiratory arousal index. It is very effective because it reduced the AHI from 30 events to 3 events per hour. However, when we give APAP to these patients, the compliance rate was only 45% because they are not comfortable, and it's the first time they use it in the post-op because these are newly diagnosed OSA patients, and the usage is also low. It's around 2 to 5 hours per night. We actually look at our pre-op, and we find that about 50% of our patients are consistently adherent. A lot of these patients, 50%, are non-adherent to CPAP. But those who are on adherence to CPAP, they require less supplemental oxygen in the post-op. So we also did another systematic review and meta-analysis, and we find that in the literature, the PAP therapy was associated with a decreased risk of post-op respiratory complication, and also associated with 28% decrease in risk of post-op respiratory complication. And the unplanned ICU is also reduced by 56%. The cardiac complications are also reduced. Post-op atrial fibrillation also reduced. So essentially, in summary here, is the PAP therapy in the non-cardiac surgery, they would decrease the respiratory complication, decrease the unplanned ICU admission. In the cardiac surgery, they would decrease the cardiac complication and post-op atrial fibrillation. So this is another example or theoretical example of pattern of respiratory arrest. And if the patient has sleep apnea, they would have apnea, and they would breathe again. They have repeated apnea episode. And during this time, the SpO2 may drop, and the PaCO2 will increase. And then ultimately, there will be terminal apnea and arousal failure, and the time of the arousal arrest. So in conclusion, the OSA patients, they are likely to have better periop monitoring because they are diagnosed. The undiagnosed sleep apnea, the unrecognized sleep apnea, or the untreated sleep apnea patient, they often get into trouble. So surgical patient with sleep apnea, we should try to screen this patient to risk identify this patient. And then we should try to institute risk mitigation measures to prevent anything happening. And we should manage and monitor these patients appropriately after surgery. Remember, one death is too many. So in the 70s, there is MH, and everybody's worried. And we will ask the family whether there's past history of problem with anesthesia, whether they have family history of problem with anesthesia, and rule out any MH susceptible patient. And if there is an event that happened MH, we have Dentalin, and we have protocol. So essentially, are we asking patients whether they have a history of sleep apnea? Are we screening for undiagnosed sleep apnea? And sleep apnea has a genetic component. And if you have a brother or sibling or parents who have sleep apnea, you will have the genetic component of sleep apnea. You're twice likely to have sleep apnea. And we have to rule out suspect sleep apnea patient by screening and CPAP treatment if needed. So I have to thank all my colleagues and fellows and students and master students to help me in this work. Thank you for your attention. I'm open to any questions or anything.
Thank you. Thank you very much, Professor Chung, for that excellent and insightful presentation. We're going to take a short break for 1 minute before we go on to the Q&A session. Please feel free to drop your questions in the chat box.
We are excited to announce the first Malaysian Perioperative Medicine Symposium 2026. Jointly co-organized by Malaysian Perioperative Medicine Society, Malaysian Society of HPB Surgeons, and Malaysian Society of Regional
As we are
Anesthesia.
waiting,
The shared goal is to improve perioperative outcomes
Dr. Yamini,
and reduce
you are
morbidity
sleep physician
through
as well as an
coordinated, evidence-based
anesthesiologist,
care.
or you, yeah.
It features 3 parallel tracks and covers a comprehensive range of topics, including prehabilitation, nutrition, and preoperative optimization, enhanced recovery pathway development, acute and regional pain management strategies, perioperative blood management, and multidisciplinary models for improved surgical outcomes. We invite you to participate in this historic first symposium and to share the event with your colleagues, trainees, and professional networks.
Okay, so we'll now open the floor for questions. So for those of you joining us on Zoom, please feel free to type your questions in the chat box. And if you're watching on YouTube, you can post your questions in the YouTube chat as well. Okay, so while waiting for the questions, I just would like to ask Professor Chung. So the problem for us is that we need to screen all patients who are going for surgery for OSA because as you mentioned earlier in your study, there's 20% of patients develop cardiovascular events within 30 days of surgery. That's a shocking number. So the thing that I want to ask is, we screen them with stop bank screening tool if they are at a risk, if they are at an intermediate risk, like 3 and above, then they are supposed to go for a sleep study, at least level 3 sleep study. But the issue is that our waiting list for this level 3 sleep study is quite long. So we can't really delay surgery. I understand that you mentioned there are only 3 main reasons to delay, which is hypoventilation, hypoxia, and severe pulmonary hypertension. But what do we do in the event that these patients cannot go for a sleep study before surgery?
So essentially, we in Canada, we also is different from USA because in the USA they have private care and you have to pay for a lot of the tests, you know. In Canada, all our health services are free, so we don't have to pay. So there are some restriction as well on resources. So we actually will understand the patients, and we don't actually send the patients for sleep study. What we do is the anesthesiologist will decide when they evaluate the patients, and then they often a lot of time common sense is good, and also observe the patient's behavior during the anesthesia, and also most importantly in the PACU. Because if in the PACU, the nurses in the PACU will be able to tell you, oh, this patient actually stopped breathing a lot, or they are having hypoxia, or if they actually have a lot of pain, but if you give them a little bit of medication, they will be very drowsy. So it's a pain sedation mismatch. So the nurses are your best friend because they will observe the patient and feel that that patient may be suffering from some serious sleep apnea. I think with that, we will decide whether to monitor the patients further or we actually don't monitor the patient. So it is due to the resource limitation, we do not send every patient for sleep study. We only rarely send patients for sleep study pre-op. Yeah. And then afterwards, it is the decisions of the anesthesiologist who evaluate the patient and who observe the patient in recovery room to decide what is the best course of action. Yeah.
Thank you very much, Prof. Chung. Another question is that have you actually, in patients who are at very high risk, severe OSA, and they have cardiovascular comorbidities, and we can't really do a sleep test on time before surgery, do you by any chance give them a pre-op CPAP for a few days? Does it make any difference?
Well, with our study that was done on APAP, which was given 3 days, yes, automatically they will have better outcome in terms of AHI. And at the present, the systematic review did indicate that there are some benefit, but we still need to do much more larger study before we can say conclusively it is beneficial. So at the present, we are not giving these patients prophylactic APAP, but if the patient needs in the PACU or post-op, we can ask the RT to come to give non-invasive ventilation or CPAP.
Thank you, Prof. Chung. We have a question on the chat box. Okay, I'll just read it out. Just as how the concept of BMI and the ranges were designed based on the Caucasian population, and therefore not quite the same in risk prediction for the Asian population, would it then perhaps be prudent for us to accept that a similar discrepancy may also exist with the stop bank score? Therefore, in the local Malaysian context, a stop bank score of 2 for a patient with Malay ethnicity should raise a similar concern compared to say a patient of Chinese ethnicity with a stop bank score of 5. What are your views on that, Prof?
Okay, I actually want to show that slide because I think actually, let me see whether I can get out of this and go back to that slide that shows the thing. I want to find the Malaysian slide because it is actually very interesting, the finding. The reasons we have that finding is Malaysia did contribute a lot to the study. So we have a lot of data from the Malaysian patient. So you can see here, actually we find the stop bang score of 4. In this, we use the data from the JAMA paper that we published in 2019. We have 1,200 patients, and a large proportion are Malay patients. And we actually find the Malay patients, they are quite obese. We have to use 35 in them, similar to the Caucasian. So this is a surprise finding for us. And this is moderate OSA. In that sense, you can see here for the Chinese and the Indian, the optimal BMI is actually 27.5% because the Chinese or the Japanese or the Indian, the BMI is lower. But to our surprise, we actually find we have to use BMI Malay. So the Malay population is quite obese. It's similar to Caucasian in terms of the population. So these are patients that are coming for major non-cardiac surgery. They are all over 45 years old. And so we do sleep study in these patients. So this is our finding because you can see if you look at stop bang 3 and this vertical axis here is a probability. And this one is for AHI 15 or higher, which is for moderate sleep apnea. And you can look at probability. When a score of 3, the Malaysian group has 40% probability of moderate to severe sleep apnea. And then 4, and then 5, and a score of 6, almost 60%. And if you look at 7, the severe AHI more than 30, which is severe sleep apnea, stop bang score of 3 is 10%, stop bang score is 15%, and 5 is 20%, 6 is 30%. So you can see here, this is 17% represents stop bang score of 4. So we should not use stop bang score of 2 to answer that question, because the Malaysian, for these group of study patients we did 45 and older, coming for major surgery, major non-cardiac surgery, and have 2 risk factors. They can either have cardiac disease or they actually may have diabetes, so they have cardiac risk factor. And this is our finding. Yeah.
Thank you. Thank you so much, Prof. Do we have any more questions? Let's see. Okay. So far, I don't think we have any more questions. So Prof, I just want to ask you, as you mentioned, on day 3 post-op, patients have higher severe apnea, apneic events. Is that true, as you mentioned?
The AHI event on that day, a lot of people are worried that on the 3rd day, actually the events are very high on the day 1. But the reason is when we show it in here, we can see this one here, this one. So you can see on the night, this is pre-op, this is the night of surgery. And this is night 3, but it's day 2 after surgery. So because we consider night of surgery as first day. So essentially what happened is the first night, a lot of these patients, about 70% of these patients, they receive oxygen therapy. But by night 3, only 7%, because by night 3, the surgeon and the resident, they would take off their oxygen. So therefore, the hypoxia is actually related to oxygen, may not be getting worse in that sense. Yeah.
And on this night is when we would expect the REM sleep to be longer, right?
The REM sleep actually, we actually look at the REM sleep. We did not find, because in the literature, everybody have say there's REM rebound on the third night.
Yeah.
And it is by Dr. Dick Neal who did the original study. But his study is not in sleep apnea patient. And also his study is in female who are coming for gallbladder surgery.
Okay.
And he actually have the patient, he has a simulated room for the patient to sleep in the night before surgery. So they may not be sleeping very well. So he did have REM rebound. But when we look at our sleep apnea patient, we did not find REM rebound. And these are mostly male. These are patients coming for non-cardiac surgery, major cardiac surgery. And also these patients sleep at home. So they may be sleeping better. So we did not find REM rebound in our group of patients. Yeah.
Thank you. Thank you so much, Prof. I think we don't have any more questions on the chat box. Let me just check. Yeah, I think we don't have questions on the chat box. Let me just wait for a while. So I think we'll end here, Prof, since we have
Okay, thank you very much for inviting me to talk. Okay, see you again.
everyone
Bye-bye.
joining us today, and we hope you found the session useful. And a big thanks to Prof. Dr. Chung for sharing her expertise and for such an excellent presentation and bearing with my questions. And before you leave, please do take a moment to scan the QR code and complete the feedback and CPD registration form. Thank you once again, and we look forward to seeing you on our next webinar.
Okay, thank you. Bye-bye.
Thank you so much, Prof. Chung.
Bye. Bye-bye. Good night.